Welcome to AETCM, the Emergency Medicine channel. Today I will be presenting a case of a 52 years old male who presented to our ER with complaints of giddiness, multiple episodes of vomiting, tinnitus in both ears with complete left-sided hearing loss since 1 day. On our 10-second initial assessment, airway was patent, no pooling of secretions, breathing was bilaterally equal chest movements, air entry bilaterally equal, no added sounds, saturation was 99% on room air, respiratory rate of 18 per minute. Circulation, heart rate was 88 per minute regular, BP was 170 over 100. Disability, GCS was E4, V5, M6. Pupils were equal and reacting to light, moving all four limbs. Exposure, GRBS was 280, temperature was 98. Adjuncts of primary survey, ECG showed normal sinus rhythm and VBG showed no acid-base imbalance.
So adjuncts to primary survey, what all adjuncts will you plan in this scenario? Primary survey, everything is normal. Patient's complaints were
giddiness, multiple episodes of vomiting, tinnitus in both ears, and complete left-sided hearing loss.
Hearing loss. Okay. Since
1 day.
1 day. Okay. So if it is very acute presentation and if you are suspecting like giddiness secondary to hypoglycemia, you will have to check the GRBS.
GRBS.
Then ECG and VBG, why was it asked?
ECG was taken to rule out any cardiac event.
It is unlikely in this scenario. Adjuncts to primary is the most emergency ones which you feel the patient might be having. That only needs to be taken. Okay.
Coming to the secondary survey, 52-year-old male who is a known case of type 2 DM, diabetes mellitus, hypertension, CKD stage 3, old pulmonary TB, mixed hearing loss, right greater than left. Now came with complaints of giddiness, which was described as a spinning sensation of his surroundings since 1 day, which was acute in onset and progressively increased. It aggravated with postural change and it reduces on lying down. It was associated with 5 to 6 episodes of vomiting which contained undigested food particles, not blood or bile stain. He also complains of complete hearing loss of left ear associated with tinnitus in bilateral ear since 1 day. There is no history of any unilateral weakness, angle of mouth deviation, sensory deficits, slurring of speech, headache, trauma, fever, loss of consciousness, no history of any ear pain or discharge. He also has no history of any allergy to any medications. Past history, he had similar episodes.
So this was the present history. So what all things you tried to rule out with the history in this patient?
First, we try to rule out if there is any central causes, if there are any neurological, any other dysfunctions in neurology.
So to rule out central cause, what all central causes are you suspecting? This patient is having giddiness. Okay, what all central causes will you suspect?
Central causes, we can suspect for a stroke, as in cerebellar stroke or a brainstem stroke.
Then sometimes there can be any migraine, vestibular migraine. That can also because of a central cause, or any bleed to the posterior aspect of the brain, especially cerebellum, those region bleeds. Then or you can suspect any lesion, ICSOL lesions. That will not present with the 1 day history, but these are the central causes which you should suspect. So what were the history pertaining to that? You asked for weakness.
Weakness, unilateral weakness, or angle of mouth deviation, facial asymmetry.
That is for the 7th cranial nerve.
Brainstem involvement. Then for the sensory deficits also, and for any
sensory unlikely. Maybe the sensory part of the face will be affected because the 5th cranial nerve, that will be going up to the brainstem. So only the face will be affected. Otherwise, the body is controlled by the thalamus region. So then slurring of speech,
headache, headache or trauma to the which we suspect for hemorrhage, any cerebellar hemorrhage, brainstem. Then fever, that is for the peripheral cause.
It can be because of central cause also, because their patient can have cerebellitis. That can also present with the same complaint. So fever history is important. Then vomiting can come in stroke or central cause and also peripheral cause also. Then what else? Hearing loss can come in central and peripheral cause. Then
Then peripheral also ear pain and discharge otitis media to rule out.
Ear pain, discharge or any ringing sensation of the ear. Then
any previous history of any fever, rhinitis, cough, any upper respiratory tract infection, viral infections.
What are you suspecting by asking this recent history?
Suspecting for vestibular neuritis.
Okay.
Then
along with giddiness, sometimes this giddiness itself can be suspect. Some patients might be telling us a same complaint. Sometimes it can be mistaken with syncope and pre-syncope. So we need to ask specifically for any loss of consciousness, whether the patient had. The patient is telling that patient fell down, lost consciousness, then recovered fully. Then it might be because of the syncope. Otherwise, if the patient is telling that patient felt giddiness for some time, patient recovered after some day, it can be a TIA also. Otherwise, it can be pre-syncope. That means patient was about to fall, then just immediately after that, patient got up. So we need to differentiate with the history. We need to differentiate syncope, pre-syncope, and also TIA. Okay.
Now coming to the past history, he had similar episodes of giddiness and vomiting in the past. He had around 2 to 3 episodes in the last 3 to 5 years, and he is on beta-histine for the same.
Okay.
On coming to the examination, he is conscious, oriented, no pallor, icterus, clubbing, cyanosis, lymphadenopathy or pedal edema. Coming to the CNS examination, there is a horizontal nystagmus which is unidirectional with a fast component towards the right with fatigability. And on coming to the hearing test, we did the Rinne's test for the left ear. There was no air conduction or bone conduction, but in right ear we could get air conduction more than bone conduction, which is suggestive of a sensory neural hearing loss.
How will you do Rinne test?
Rinne's test, we have to, with the help of a tuning fork, we'll have
what
to...
What is the frequency of the tuning fork?
We can use 128, 256 and 512.
512 will be sufficient enough. 512 is for hearing and 128 for the vibration. We need to check for any diabetic peripheral neuropathy and all. Vibration sense, we will be using that. Then how will you do the Rinne test?
So after hitting it on our palm, we will bring it initially to the ear, and we'll ask if the patient is able to hear, and then we'll keep it over the mastoid, and we'll again ask if the patient is able to feel it or not, hear it or not.
What is the normal you are expecting in Rinne test?
Normally, air conduction should be more than bone conduction. We'll also check for the time. Once he starts to hear and when he'll not hear, we'll check the time interval, and we'll also check the same time interval for the bone conduction also.
So we want air conduction to be more than bone conduction. So either we can do in vice versa also. You can ask, you can beat it and keep it at the mastoid process. Ask the patient if the patient is feeling that vibration sense. Ask the patient to tell us when the patient stops that feeling. Once the patient is telling that it stopped, then you can bring it in front of the ear. And if the patient is still hearing, that means that after more than bone conduction, air conduction is there, which is normal. Which will be affected in which one?
It will be affected in conductive hearing loss.
Conductive hearing loss. Like any tympanic membrane rupture or any foreign body in the any foreign body in the external auditory canal or any middle ear infections, it will be affected. Okay. Weber's test, how will you do?
Weber's test, after beating it, we will keep it over the central bony prominence, and we'll ask the patient where he's hearing the sound more. We'll check for lateralization of sound. In conductive hearing loss, it will be towards the towards the normal ear.
Normal ear. So it means bone conduction, Weber will lateralize to the Weber's test. If it is a conductive hearing loss, it will lateralize to the affected ear in conductive hearing loss. And Weber will be lateralizing to the normal side in case of sensory neural hearing loss. Okay.
In this, and Weber's test was done, there was no lateralization of sound. Coming to power, it was 5/5 in all limbs. Tone was normal in bilateral upper and lower limb. Reflex was 2+ in upper and lower limbs. And there was no upper limb incoordination. Bilateral plantar was flexor. Patient could not sit due to the giddiness. So we were not able to assess the straight line walking test. And there was no neck stiffness.
Okay. Then what you can do is, if we want to rule out peripheral versus central, so we can look for any facial nerve asymmetry, facial nerves also. You can ask the patient to smile. If there is any facial asymmetry, UMN or LMN, anything is involved, we can see. If it is LMN, we can suspect as a peripheral cause. If it is UMN, central cause. Then if the patient is not able to sit up, you can ask the patient to do finger nose test. Then also finger nose test, finger to finger test, and heel knee test can be asked to do. But any pass pointing can be diagnosed that way, and you can ask the patient to do dysdiadochokinesia also. Okay. Then slurring, how will you test slurring? You can ask the patient to pronounce a complicated word like Thiruvananthapuram. If the patient is able to tell that properly, then it will be unlikely the patient is having slurring. Okay. Now the importance of ECG comes in this moment. If you are feeling that it's after doing the CNS test, and if you feel that it is something like a central cause, then you can ask for an ECG, because you are suspecting a stroke. If at all suspecting a stroke, you can ask for ECG. So in ECG, if you are seeing an AF, we can suspect an embolic stroke. Or if it is a cerebellar T waves will be seen, that means inverted T waves will be seen in case of a stroke. So in that scenario, we can plan on doing an ECG. Okay.
We also did a head impulse test in which the patient's head was turned 10 degrees, and he was asked to focus on a distant object. And suddenly...
How will you turn the head? Like this or rotate?
Like 10 degrees
like this. Like this. Not like this. Okay. Ask the patient to focus on one object and turn like this. And
then again, so after...
while we will fix the head like this, we'll rotate, and immediately we will give a jerk to the patient. What are you checking in that?
The patient, in a normal patient, he should be able to fix on the object even when we turn the head. But if he has a peripheral cause, if a labyrinth, like labyrinth is involved, then the patient will not be able to focus on the object. He'll look away, and there will be saccadic movement back to the
saccading to the normal target.
To the normal target.
Saccades will be there. And then what about in central cause?
In central cause, he will be able to fixate on the object.
Central cause will be looking like normal, but if the patient doesn't have a saccade, then that means there might be a central cause. So we should be planning on doing a neuroimaging for the patient.
Then we can also look for a skew deviation test as well, in which we will make the patient to cover one of his eyes, and again we'll suddenly cover the other eye, and we'll check if there is any vertical movements.
Vertical nystagmus.
Nystagmus in the...
We can alternate and cover both the eyes, and we will have to ask the patient, like the previous case, we'll have to ask the patient to either to fix the gaze on the examiner or to examiner's nose or somewhere. And as you change, if you are seeing any vertical nystagmus, that means
it can be a central
cause. So vertical nystagmus and will be coming in central cause. Skew will be coming in peripheral cause. Okay.
Then rest of the systems were within normal limit. So coming to differential diagnosis at this point of time.
Do you want, so this patient's anyway central cause is ruled out. How did you rule out with the central nervous system examination? Then you have done the skew test, and also the head impulse test.
Nystagmus also.
Then we need to find the peripheral cause. What test you should do in peripheral cause?
We can also do the Dix-Hallpike maneuver to diagnose for BPPV.
Okay.
And
how will you do the Hallpike test?
Dix-Hallpike maneuver, we will initially make the patient to sit up, and we'll check for both directions. First, we'll tell the patient to look onto the right side in a 45-degree angle to check for the right posterior semicircular canal, and will make the patient lie down, and we'll hyperextend the neck to 20 degrees, and we'll hold it in that position and ask for the patient for any giddiness, dizziness, and we'll also check for at the same time for nystagmus. So the nystagmus will come around 2 to 5 seconds after that position, and will last for around 30 seconds. If there's any symptom or any nystagmus is there, then most probably the issue will be with the right posterior semicircular canal, and we'll bring the patient, we'll make the patient come back up, and if it's negative, means we'll repeat it on the left side also to check for the left posterior semicircular canal.
Okay, what precaution will you take before doing Hallpex?
We'll make sure that the patient does not have any history of any cervical spine trauma or any cervical spine surgeries in the past, or also we should ask for any cervical disc prolapse history or any other vascular causes such as vertebrobasilar insufficiency or dissection.
Okay. Any medications to be given before the test?
Yes, we have to give him antiemetics before the test so that he won't be when we reproduce the symptom, he won't vomit.
Okay. What will give a false negative test?
False negative, we should if we give an antihistamine prior to the test, he might not be able to reproduce the symptom. He will miss the diagnosis.
Okay. So what are the then anything else? Then if Hallpex is coming positive, we will have to
do based on which side it is. We have to do the Epley's maneuver for correction.
Okay. So what were your DDs in this case?
DDs, since the patient, based on the symptom of the patient, is having recurrent episodes of similar giddiness as in vertigo. So and along with that, he is having tinnitus, and also he is having complete hearing loss, acute onset of complete hearing loss. So it might be a case of a Meniere's disease, which is one of the DDs, or it can also be BPPV, second DD.
BPPV is unlikely to have any hearing loss
or tinnitus.
Hearing loss.
Maybe it can also be a vestibular neuritis, but he has not given any past history of upper respiratory tract infection.
Okay. It can be labyrinthitis also. Labyrinthitis can come secondary to HSV infection, and after that patient can have inner ear and the 8th cranial nerve getting affected, and such patients can have hearing loss also. Sensorineural hearing loss along with giddiness, tinnitus and all. Okay. What will be the characteristic of vertigo in case of a central cause and peripheral cause? How will the patient tell the vertigo?
In a peripheral cause, it will be a spontaneous onset of the symptoms, and it will be changing with postural.
That means it will be mostly vary, especially in BPPV. It will vary solely with position. Patient is, when the patient is lying down, patient will tell that I am asymptomatic. When the patient is trying to sit up, the position worsens. The vertigo worsens. Whereas in central cause, even though patient is lying down, it will be there.
Still be having symptoms.
But in vestibular neuronitis, it will be somewhat like a central cause itself. Patient will be having this vertigo while lying down and also sitting position. So central cause and peripheral cause, central cause and vestibular neuronitis will be having the symptoms, prolonged symptoms will be there, and it will not be changing with position. So in such scenarios, we will have to do the Hinds test, which we have already mentioned previously. What is the full form of Hinds test?
Hinds test is head impulse test with the nystagmus and the skew deviation.
Then also hearing loss is there. So first we will have to, once BPPV will be having, patient will not be having any giddiness while the patient is lying down. Okay. So if we are confused between vestibular neuronitis and stroke, that or any central cause, then we will have to do the impulse test. So now we will have to differentiate between the nystagmuses. How will be the nystagmus in case of vestibular neuronitis?
In vestibular neuronitis, it will be horizontal nystagmus and it will be unidirectional.
Unidirectional. So what does unidirectional mean?
Unidirectional means if he is looking to right side, I mean, like if in looking at the right side, if it's in beating in one side, even if you look to the opposite direction, also it will be in the same side.
Okay. So if left side is affected, patient, even though patient looks left or right, the nystagmus will be beating to the same side. Both sides patient, even though it is called unidirectional, that doesn't mean that in one direction only patient will have nystagmus. Patient, whichever side patient is looking, patient's nystagmus will be pointing out to the affected side. Okay. Whereas in peripheral central cause,
there can be a vertical nystagmus and also it can be bidirectional.
So whenever the patient is looking to one side, nystagmus can be to other side. Anyways, both the sides patient will be having nystagmus. The pars component will point out to both the sides. Okay. Then we have already mentioned about the cover test. Cover testing, we will be seeing vertical nystagmus in case of a central cause. Then when you check the head impulse test, that will be normal in case of a central cause and affected in case of vestibular neuronitis. Okay. And sometimes central cause patient might be having a hearing loss also. Both the cases patient can have hearing loss. Okay. Then what about the hearing loss? When will be the hearing loss be present? In labyrinthitis it can be there, Meniere's it can be there. So we need to differentiate in this patient whether it is Meniere's or labyrinthitis. Okay. Then how will you proceed with the investigations?
Then we can do a pure tone audiometry
to confirm the type of hearing loss.
Sensorineural or conductive hearing loss. Then we can do a MRI to rule out central cause and also to check for the endolymphatic duct.
So MRI we are doing not to rule out a central cause. Here anyway we are getting more towards a peripheral cause. So we need to see what is happening inside the ear. So for that, in order to differentiate between a labyrinthitis or a Meniere's disease, we have to do the MRI to lymph for any endolymph. Okay. And what was there for this patient?
There is bilateral mastoid effusion in the MRI.
Okay. So some lymphatic drainage problem was there. Okay. Anything else?
Then you can also do electrocochleography in which summating potential summating potential and action potentials are divided and it should be greater than 40%. It is diagnostic for Meniere's disease.
Okay. Was that done? Yet to be done.
Yet to be.
Okay.
Coming to treatment, for this patient, we can for the symptomatic management we can start him on antihistamines like beta-histine, dimenhydrinate.
Only after examining the patient, after ruling out the central versus peripheral only we will be starting this. Okay.
Then we can if the antihistamines is not helping, then we can give benzodiazepines. And for the vomiting we can give antiemetics, ondansetron or metoclopramide. And we can also for the Meniere's disease as such we can give diuretics to reduce the endolymphatic and steroids can be given to reduce the production. Then we can also we can also do a endolymphatic sac decompression, or we can put a Meniere's device. Meniere's device is used for draining the excess endolymph. Or we can also do a medical vestibulectomy by injecting intratympanic gentamicin.
Okay.
Those are the options.
Anything else?
Then we have a diagnostic criteria, which is not named one, but in that there is 2 or more.
Diagnostic criteria for Meniere's disease.
So in that we need at least 2 or more episodes of vertigo, which is spontaneous, and it should last when the single episode. Each episode should last for 20 minutes to around 12 hours. Then audiometry done should show a low to middle frequency sensorineural hearing loss. And then also you should be having third point is fluctuating oral symptoms, as in tinnitus or fullness of ear. And also there should be no other vestibular diagnosis for this patient.
Okay. So to conclude, can you conclude this case? Or how should the audience be coming to an impression with the case of vertigo?
First, initially we have to take proper history and we have to differentiate between the central cause and peripheral cause, and we should confirm it with our physical examination, and we should also.
Okay, so if the patient is having continuous vertigo all the time, continuous vertigo, it can be either because of a vestibular neuronitis and any central cause, or it can be because of a labyrinthitis or vestibular neuronitis. Whereas if the patient is having on and off positional or paroxysmal vertigo, it can be because of a BPPV or Meniere's disease. So in order to differentiate this each of Meniere's or BPPV versus labyrinthitis or vestibular neuronitis, we'll have to check for the hearing. If the hearing is affected, it can be Meniere's disease, or if there is persistent vertigo and we need to know whether it is vestibular neuronitis or labyrinthitis, again hearing test. Hearing will be affected in labyrinthitis. Vestibular neuronitis, it will not be affected. Okay, thank you.